All right. Well, in the interest of time, I'll go ahead and get things started. Thank you all so much for joining us for this encore of a presentation we actually did live at this year's 2025 Oley conference. It at the time was entitled the Industry Reimbursement Summit, which we have recently renamed really to capture our aim, industry viability, working together to preserve access to quality care. Before we go ahead and start the presentation, I did want to highlight some of our wonderful upcoming events. Be sure to follow us on social media and be checking our website for some amazing opportunities next week, as we are a proud ambassador of Malnutrition Awareness Week and are partnering with Aspen to kick off Malnutrition Awareness Week by speaking on the very important topic of patient safety failures and how that compounds and potentially contributes to malnutrition rates, and brainstorm some solutions of how we can partner and work together to address this. We also have an exciting opportunity for those of you local to Florida or beyond. Our regional conference, our day-long educational event here for me at least, in Kissimmee, Florida on September 20th. We also have our monthly community connections meeting later on in September, and then more to come soon in October for Home Parenteral Nutrition Awareness Week. For all things Oley, be sure to check us out on oley.org and follow us on social media. As always, the information presented within this presentation is for informational purposes only. With that being said, I'd love to learn a little bit about who's joining before we start the presentation. John, would you be able to pull up the first question? What best describes your connection to nutrition support? Looks like we've got a good mix, industry being the majority, that and healthcare providers, which is what we anticipated. This is our target for this webinar. Awesome. And of course, we have some good consumer representation. I'd also like to learn, John, next question, where everyone is calling in from. Where do we have representation from? Looks like Florida's coming in strong. Oh, good, good. We're spread out. Georgia, Pittsburgh, Virginia, Texas, New Jersey. Awesome. And that was really the aim of this presentation originally, and this encore is to pull representation nationally. This is great. All right, so now that we've learned a little bit about you, thank you for your responses. Let's go ahead and get things started. John, will you hit play?
I'm Crystal Killian. I'm a PM patient advocate. And the reason it is so important to me is multifaceted. One, because I don't know the cost that goes into my parenteral nutrition. I do know the complexity of making parenteral nutrition, and it is without parenteral nutrition, I would not be here today. So we will then have everyone else introduce themselves and say why they're here. And we'll start with Kaylee.
Hello, my name is Kaylee. I'm a registered dietitian and I am the manager of education for the Oley Foundation. And my why is how much the issue of reimbursement is impacting not only a patient and consumer access to supplies and resources, and like Crystal mentioned, what they need for their lifeline, but also how much it's impacting quality of life and patient safety.
Hi, my name is Jessica Yonkman. I'm a clinical nutrition manager at Solio Health. I am here because I feel passionately that, we need to provide services to all of our patients as best we can. And I do feel that reimbursement has truly been affecting access to care for patients. And I just feel the need to do something else. So I joined Oley to start this discussion.
Hi, I'm Amy Braglia-Tarpey. I'm a dietitian as well as the Director of Nutrition Product Line for Emeritus Specialty Infusion. And I'm here today because not only is the current environment for reimbursement impacting our patients and our patient care, but I see it impacting my team of clinicians at my organization and their frustration with all of the additional day-to-day work that we have to do in order to obtain reimbursement for therapy, in addition to clinically managing patients and communicating with patients and trying to do a good job taking care of patients.
And so the agenda today is, as we just went over our introductions, then we'll go over the current problem, the current state of affairs on both enteral and parenteral reimbursement. And then we'll do some level setting so everyone understands the process of which we receive enteral and parenteral nutrition. And then Jessica and Amy will review some of the data that we currently know. And then we will go over the committees and some of the next steps so that we can go on. The big problem is parenteral and enteral nutrition's reimbursement rates are purely inadequate to support the quality of life, the quality for patient care, and the quality and viability for companies. Many companies cannot stay afloat with the current reimbursement rates that they are receiving. And Kaylee will go over the current state of affairs of supportive nutrition.
Sure. So the issues of reimbursement systemically are compounded by product shortages, lack of redundancy and product choice, as well as rising costs. As Crystal mentioned, we're also working against an outdated reimbursement model and stagnant rates. So you have that and rising costs, which do not equate to success. And then on top of all of this, we also have an overall lack of expertise in PN, EN, central line care and management amongst prescribers and agencies, further impacting accessibility. This results in company consolidations, issues with access to care and services and care management, as well as really decreased ability for prescribers and then for patients to have tailored nutrition regimens and really their regimens individualized to meet not only their nutritional needs, but to also address their health goals and really optimize quality of life.
I'm going to pull the curtain back on behind the scenes of parenteral nutrition. It is the most complicated compound that infusion pharmacies make. It starts off with a script from a doctor. That is, if a patient can find one that knows how to write the order of parenteral nutrition. The script then goes to the infusion company. It is evaluated to see if they can formulate the PN. This includes looking at the components that make up your parenteral nutrition. Not all infusion companies have contracts or carry different components, for example, different amino acids that could be needed. The patient's insurance has to be checked to see if the pharmacy takes it and what the coverage will be. There is also a clinical review of the formula versus the patient's lab, usually done by the dietitian or the pharmacist, to ensure that the parenteral nutrition meets the clinical needs that are appropriate. Once the pharmacy accepts the patient and the script is complete, the components to compound the parenteral nutrition is taken from the warehouse and transferred into the clean room. There lies a big question. Does the pharmacy have all the components needed for the formulation of the PN in stock? Who knows? The industry is always juggling with some shortage here or there. Preparing the clean room is not easy. is not as easy as many people think. There's a lot that goes into keeping a clean room, some of which include the testing that goes into the clean room and maintaining it, the environmental monitoring and other testing in accordance with USP 797, which governs 503A compounding pharmacies, which the infusion pharmacies are. The cost of gowning and the cleaning and decontamination agents that keep the clean room and the hood ready to do aseptic formulation. Once everything is ready, the pharmacy tech then can formulate each batch to match each patient's unique script. Then it gets sent back out of the clean room to the packaging area where it's packaged with the consumable goods that the patient needs, like the tubing, the change kit, all those other things, some of which can be very customized to the patient. And then it's sent to the patient either by a courier or overnight delivery, depending on the services. Once this is done, it triggers the invoice and it goes to the billing. So the billing team then is working with billing, insurance, which is a revolving cycle. And depending on how much or even if the pharmacy will get paid. This also leaves the patient in limbo as they don't know if they're going to have a bill, not have a bill. So both the industry and the patient are questioning how much they're going to get paid or have to pay.
So for TPN, for parenteral nutrition, there's a difference between what is actually supplied to the patient in terms of the formula and supplies, and then what is actually reimbursed. So a home infusion pharmacy at minimum is going to provide all of the PN components that are prescribed. So that includes the dextrose, amino acids, electrolytes, vitamins, and minerals, among other additives as well. They're going to provide the infusion supplies, which includes the pump, the tubing, the bags, clean supplies, testing supplies, the lab supplies. They're also going to do the compounding. So the techs and the pharmacists are part of the home infusion pharmacy staff that they complete the compounding. There's also cost for the equipment, supplies, and facilities. There's also clinical expertise. So for many people who are on parenteral nutrition, their prescriber is not adequately trained to manage parenteral nutrition. And so therefore, the expertise from the infusion pharmacy dietitian and pharmacist are paramount to make sure the patient has a prescription that's appropriate and that promotes their health goals, as Kaylee said earlier. We also include in the bundle of what we provide for patients central line care. So we have the supplies for that to maintain a sterile environment when you're connecting TPN, as well as a nurse to teach that, and then lab draws as well on the weeks when you have lab draws. And then there's pump maintenance and management. So that takes staffing, there are maintenance costs, there's software, there's programming by either a pharmacist or a nurse. And then lastly, there's also shipping costs that occur. So that would include the delivery coordinator and warehouse personnel, et cetera. So what is actually reimbursed out of all those things you just heard, that laundry list of things? 1 bag per day of home parenteral nutrition based on the volume or of the amino acid content is reimbursed. Lipids are reimbursed separately from that, what we would call the 2-in-1 part of the TPN. Nursing visits are reimbursed by many payers, although not all payers reimburse for nursing. The supply kit is reimbursed and the infusion pump is reimbursed. So there's all these other services that are wrapped up that are not reimbursed in and of themselves. And so the total reimbursement has to account for all of those costs that are incumbent in providing parenteral nutrition. So I'm going to pass it to Kaylee now, and she's going to give us the similar process for enteral nutrition.
Sure. So mirroring what's been discussed in terms of process flow for parenteral, on this slide you have depicted Some of what's going on front facing the consumer and the patient, you'll see in that first row here, we have basically the process of calling in and ordering supplies, whether you're a new patient or you're a current patient placing a refill, or maybe something in your regimen has changed and you're calling to request supplies. This is also somewhat of a gatekeeping process in that there are contracts behind the scenes that as consumers and patients, we might not be privy to in terms of contractual agreements with different manufacturers or companies limiting what you may or may not have access to from that particular medical supplier, whether it be a home infusion provider or your durable medical equipment company. So that is kind of step one of potential access or option restriction for patients. Then moving on to the next step, let's say, you place your order, they're keying it. For the patient, then it becomes the question of, all right, is everything in stock? This translates to, when is this going to get to my home? Is this going to be a same day delivery? Does this have to be a special shipment? Am I only going to get a partial? Am I going to have to face potential alternatives or substitutions being shipped to my home because of supply chain shortages, or maybe just poor stock at the warehouse? And then from there, hopefully delivery to home. You see that smiling delivery service with all the boxes. Was everything actually delivered in the boxes? We hope so. And then that translates to nutrition support at home. But, kind of similar to what we saw in the PN slides, we have a lot going on in the back end. Communication regarding this process varies greatly in transparency back to the patient and consumer. So the prescription is sent in, it arrives to the DME or the home infusion provider, and you have these just turnover kind of cycles in terms of potentially Medicare qualification and review or insurance review. With enteral, it's multi-layer, which I'll cover in just a moment in terms of what this insurance approval and coverage process looks like. It can become very complicated based on a variety of factors. And then from there, this determines if this is a prescription and a patient that the company would be able to service, and then what does that reimbursement rate look like? Is this a profitable prescription or referral or service line for the company? If not, what changes may need to be made to the prescription? Will we be able to continue? So the layers of EN coverage and access, I liken this to the song, it's going to be stuck in your head, How a Bill Becomes a Law, working your way through the pyramid of enteral nutrition prescriptions. You'll see that first layer, the bottom of the pyramid, being that insurance review process or Medicare qualification. In the eyes of reviewing for potential coverage, it goes through several different criteria categories. At the very basic, making sure that what's being received is a valid order. And then from there, whether it be Medicare or commercial insurance, does the patient meet certain clinical criteria, ICD-10 codes? What's their age? Oftentimes individuals will age out depending on state and payer in terms of enteral coverage. What's the HCPCS category? What are we billing for? That may be restricted too in terms of medical necessity. Is this on formulary for select insurances? Sometimes they will only be willing to pay and approve what is on their specific formulary, regardless of medical or clinical need. How much is this enteral nutrition providing in terms of nutritional requirements? Is it the sole source of nutrition, the majority, less than 50%? What's the length of need? How is this documented in the EMR in terms of medical necessity? Is this just for supplies? How is the tube being used? Is it for drainage and decompression, hydration, and partial nutrition? Is this just for enteral formula? And then what is the route and method of administration? From there, there may be a secondary payer coverage process, depending on the payer combination, whether or not they may be able to pick up. And then the next layer is now further restricting potential coverage and access. Different state mandates actually creating additional age restrictions, regardless of whether or not that insurance providing coverage, essentially aging individuals out of potential access to coverage. Same with creating coverage limits. So a certain dollar amount annually that a patient may utilize for enteral formula coverage, or coverage limitations in terms of HCPCS families. And then from there, this really generating and going back to who is providing the formula and supplies, the DMEs and home infusion providers. What does this look like in terms of reimbursement rate and profitability margin? Is this something that we would be able to service, especially long term? What does this look like in terms of supply costs? If we'd be willing to work out something in terms of our individual formulary or pharmacy contracts, are we going to have to make some additional substitutions? Where it gets really discouraging is when it results to a major change in prescription and the process needs to be restarted from the beginning in terms of going through insurance approval just to generate a more favorable profitability margin. Once we've made it back up to that stage in which it's deemed serviceable by the home infusion pharmacy or the durable medical equipment company, then it's verified that yes, this is in stock, it's something that we can ship, and finally makes its way home to the consumer. So as you can see, that back end cycle of reviewing for coverage and if this is something that can actually be serviceable and delivered long term to the consumer, it gets very complicated. It's multi-layer, and you could only imagine what communication is like between all the different parties involved.
So with product shortages and rising cost, we're always in a constant state with enteral and parenteral nutrition with product shortages. The tubing pumps sets, I believe there's a shortage of that. Continuously supply chain resilience and lack of redundancy issues. We've had some major hurdles that we've had to face in the last year or so, around more than just a year, but the last year seemed to be even worse, around lack thereof redundancies. There are, in some instances, just sole source providers for some of the ingredients that go into making parenteral nutrition and some enteral nutrition that works for the patient. And then the route of parenteral nutrition components. So we're not even talking the components themselves, everything that makes up, that Amy went over, makes up your parenteral nutrition, from your lipids to your amino acids and your dextrose. All those components, how are they coming? Where are they coming from? The shipping issues. And then to add to this, what is reimbursed? One thing Amy mentioned is reimbursed is the kit, but what is the kit? Is it a specialty kit and you need a very specific dressing or a specific needle in my case? Well, that's not necessarily reimbursed at the rate that it would cost to use. So, and then the enteral formulas, they're going on and off shortages. Same as with the product portfolios. They're consolidating product portfolios because it's just not, they cannot make a line full of the product. It's not cost promoting, it's cost prohibitive. And then we're talking about rising cost. The cost of labor has gone up, and we went over pretty extensively every one that it takes to make enteral and parenteral nutrition. The supply cost we know has gone through the roof. Shipping cost, for example, just to mail a simple letter, went from 55 cents in 2020 to today it's 78 cents. And so you can just extrapolate that out when it comes to shipping materials from wherever your infusion company is or your DME is to your house. It just becomes more expensive. The as we said, the components themselves, and some of this has some underlying issues with regulations and some unintended consequences of what it has made to make it cost more. Selenium, for example, is costing more because of regulatory issues. And as Amy was mentioning, new pumps, both IV pumps and enteral pumps, the just cost of them and the maintenance and all that, all these things the costs are going up. Cost is going down in very little things. So all this is enhancing the cost that it makes to make the enteral and parenteral, to provide it to the patient, not just to manufacture it, but to provide it to the patient at a good quality to sustain their lives. But the reimbursement rate, as we will see shortly, hasn't risen much.
So last year, Aspen undertook a parenteral nutrition patient survey in 2024, and the results were released and published this year. And they heard from 170 patients and caregivers in the US who are using home parenteral nutrition. And they were really seeking to find how these access issues are directly impacting those patients and caregivers. In those results, one of the most shocking a result of this was that 32% of the respondents reported fear of losing their insurance coverage for PN. So that really stood out to me. Almost a third of patients or consumers are afraid of losing their PN coverage, among other things that you can see here on this slide that are impacting them. And then I wanted to pull out a few other specific points from the survey here so that you can see them. So Aspen asked the parenteral nutrition consumers and caregiver respondents if they had experienced any changes to their care process as a direct result of PN access issues. And what they found was that most folks did have some experience to report with burdens that were associated with access issues. Only 11% of all the respondents said they had no difficulties due to access issues. Similarly, they asked if there was any disruption or if they had any difficulty with their symptoms or exacerbations of their disease as a result of access issues. And less than 40% said they had no problems due to the burdens of PN access issues. So really pretty impressive numbers demonstrating that these access issues really are starting to trickle down and directly impact those who use parenteral nutrition. So Aspen also asked if these consumers who responded to the survey had any medical problems related to the PN shortages that have occurred, repeatedly over and over throughout the pandemic, before the pandemic, and then of course last year with the IV fluid shortage. And what they found was that 37% of respondents, only 37%, reported medical problems related to the PN shortages. And what's interesting there too is that 37% said they had these problems, but within that 37%, some of them reported having multiple problems due to the shortages. So some folks were really impacted by this pretty significantly. And that's over a third of consumers responding, saying they're experiencing these medical difficulties is pretty significant. So likewise, Aspen has also undertaken a project to better understand enteral nutrition access, but they're taking a different approach with this survey. And so they collected data from providers of enteral nutrition to ask them questions about access issues in US hospitals in alternate site facilities like long-term care and then outpatient settings, as well as in the home. And so they want to use this data to determine the extent to which access issues are affecting the adequate delivery of tube feeding or enteral nutrition formula to qualified patients. So this data collection just closed in June. The data is under review, and we expect to see a publication from Aspen sometime within the next few months.
The National Home Infusion Association, or NHIA, published a paper in 2023 discussing the impact of the pandemic on the home infusion industry. They reviewed over 400,000 bags of PN from 2016 to 2021 and found that cumulatively there was a 50% cost increase during that time. They cite multiple contributing factors, and there really does seem to be a recurring theme here. One of those major factors has been shortages, which we've brought up. And to be honest, though, we've been dealing with these shortages long before the pandemic, and we'll probably be dealing with them long after as well. Another factor is generics moving to brand names. I think the most well-known example is the reformulation of selenium that resulted in a 1,200% cost increase. It's important to know that there are no other alternative options available. And that said, given the current per diem payer model, there really is no flexibility to account for that rapid increase in cost of product. So if patients needed selenium, then those companies essentially had to take a hit for using it. Just to add here, the NHIA conference in 2025 did present some updated numbers that they collected through 2024, and they now cite a 200% increase in PN costs over the past 8 years. This is staggering, and no wonder they also cite a 16% decrease per year in the number of providers working in PN. We are anxiously awaiting this official report from NHIA, but I thought it was really important to mention, and it is referenced on their website as a recap to their 2025 conference. So we know there's a problem, but what's the solution? Well, that's why we're here, right? I will say that NHIA does make some recommendations in their paper, and these include the recommendations for payers to either consider increased cost of items and services in their per diem rates, or to review the payment policies and align them with the HCPCS codes and allow for separate billing for many of the components. When you look at what we would call like a standard PN formulation, there's many ingredients that are going to be universal, and they're listed here. But we know as clinicians, I think even patients know, that there are very few standard home PN patients out there. Many have very specific needs and nutrient requirements, and they fall well outside of the standards. There are very real clinical indications for using specialty amino acids, specialty lipids. Patients may require individual or increased dosing for trace elements or vitamins because of maybe high losses or deficiencies. You also have ingredients like levocarnitine or iron dextran that are outside of what a standard formulation would include. And that, again, patients have very real clinical requirements for. There are also medications that can be added to PN that serve non-nutritional purposes, things like insulin, heparin, famotidine, octreotide. And adding them to PN can allow for an efficient method of administration, but if companies can't reimburse for them, there's no incentive to provide them. And all of these components, they're not only expensive, but they truly require very specialized expertise to safely provide. And as Amy referenced earlier, that also increases costs and risks to the industry and really need to be considered as well.
Okay. So you've heard a little bit about some of the cost trends. I also wanted to share some data on payer trends. So last year, I undertook a data review in the population of home parenteral nutrition patients that are serviced by Emerita Home Infusion. And I looked at the payer, who was the patient's insurance plan at the time that they admitted to services to receive home parenteral nutrition from the home infusion pharmacy. And so the time period I looked at was from January of 2020 through November of 2024. And what was interesting during that time period is there was a very clear trend in that new PN admits that had traditional Medicare Part B coverage as their primary insurance declined by 19% over that short time period of 4 years. And then at the same time, the percentage of patients admitted with a Medicare Advantage plan grew by the same amount. So what's interesting is that over that same time period, the overall percentage of other payer types did not change significantly. So what we really saw was a shift in the way patients' Medicare benefits are being administered and the choices that patients are making when they become Medicare eligible in their payer type. And we'll talk more in a minute about why that's important. So this trend can be seen in the Medicare population as a whole. So all Medicare recipients, we're seeing this increase in Medicare Advantage plan election and a decrease in use of the traditional Medicare Part B benefit. But Medicare Advantage plan election rose at an even higher rate in our PN population than in the general Medicare population based on the data that's been provided by the Kaiser Family Foundation. So you may be thinking, well, who cares? Well, one thing to know about parenteral nutrition is that over many years, Medicare Part B has been the gold standard of PN reimbursement. It really provides adequate revenue to cover all associated costs of TPN. In contrast, Medicare Advantage plans are going to operate like an employer-sponsored commercial plans, kind of like an HMO. They significantly lower the cost for the payer, but that means that they lower the reimbursement for the exact same service. And so that reimbursement for that same parenteral nutrition bag could be anywhere from 15 to 55% lower in what the provider is being reimbursed than it would have been with a traditional Medicare Part B plan. And maybe more important for the consumer to think about is that this also narrows the networks of providers for parenteral nutrition. So with a Medicare Part B plan, patients can go to just about any home infusion provider to receive their parenteral nutrition. But with a Medicare Advantage plan, they'll be in network with a selected group of providers, which will limit patient choice. And then lastly, some of these Medicare Advantage plans use very archaic coverage criteria for parenteral nutrition, not really reflecting current evidence-based practice. So recently here in my organization, we had to turn away a referral for parenteral nutrition for a patient who had a Medicare Advantage plan that had a very narrow network. And we found out subsequently that 2 other home infusion pharmacies were also contacted for the referral, and both of them were out of network too. So that just illustrates the limitations of patient choice. So that all leads to the discussion about payer mix. So what is payer mix and why does it matter? So I'm going to use an analogy here. So if you look at the photos on the screen, on the right, you see a photo of a beautiful Mediterranean diet. So as a dietitian, this is always a good way for me to think about things. The Mediterranean diet is considered the gold standard of nutrition for those of us who can consume food orally. So note the variety. It's got vegetables and legumes and whole grains and olive oil. And so we need all of these different nutrients to ensure a healthy body, and we consume a broad variety of nutrients in balance. And when we don't, there could be negative consequences to our health and to our longevity. Similarly, with parenteral nutrition, it's composed of a bunch of different things that are going to provide all the nutrients you need. So your dextrose, lipids, amino acids, electrolytes, vitamins, and trace elements. When there's an excess of something like dextrose, problems like hyperglycemia or PN-associated liver disease can occur. And when there's not enough of something in your diet or your PN, deficiencies like selenium deficiency can occur. So now think about your home infusion provider in the same way. A pharmacy requires a healthy mix of payers. And so whether it's right or wrong, for many years, Medicare Part B has been a stalwart of PN reimbursement, and they reimburse very well for PN. And so when a home infusion provider has a healthy percent of their business from Medicare Part B, they can take on a percent of payers with less healthy reimbursement rates. So you can think of your less healthy reimbursement as being like the photo on the left, which is our sad American diet, or our standard American diet with lots of junk food and not a lot of nutrition to it. So think of your Medicare Advantage plans and commercial plans. Those are some of the payers that have lower reimbursement rates. But if there's also Medicare patients that are being taken care of, those kind of balance out the Medicare, the poorer patient reimbursement plans. So when you have a good balance of Medicare, that allows pharmacies to be able to take on insurances like Medicaid, whose traditional plans in many states actually pay less than the cost of service. So our payer mix right now, if you look across the spectrum of home infusion pharmacies, is really unbalanced. So we have a lot of Medicare Advantage, fair amount of Medicaid, a little bit of Medicare traditional, and it's kind of like our diet on the left. So too little of your vegetables, which would be like your Medicare Part B, too much of your Medicare Advantage plan, that's your French fries there that are going to provide you some calories, but maybe not much else. And then there's your Medicaid, which is your Diet Coke. It's just empty calories. So in fact, many home infusion providers no longer service Medicaid payers, and some of them don't service Medicare Advantage plans or some commercial plans because they reimburse little more than the cost of service, and in many cases, less than the cost of service. Now, if you're someone who works for an infusion provider that fairly limits your payer mix due to poor reimbursement, this might not matter much to you. But for all of us here who value equity and access for all people in need of nutrition support, and especially children in need of nutrition support who are likely to have a Medicaid payer, this may be the most important discussion point you have this week. So there are many access issues with parenteral nutrition, and they center around things like limitations of home infusion providers. So in many rural locations, it's difficult to access home infusion services and companies that can reach those areas, especially now that many pharmacies have exited the marketplace. There are narrow payer networks, which I already alluded to, that limit patient choice. In the last 5 years, we've seen many pharmacy and DME provider closures and consolidations, which limits choice and decreases access for patients. Innovation in products is also suffering. So products that could improve clinical outcomes are not being provided or can't be provided because the reimbursement is low or non-existent. So a few examples of this would be catheter locks, like an ethanol catheter lock, infection control supplies, sometimes various securement devices, and various enteral formulas and modulars and advanced pump systems. There are also limitations for reimbursement for IV fluids. There are not many payers that provide adequate reimbursement for IV fluids. And in fact, for Medicare, they're not reimbursed at all. So the cost is to the patient. And then lastly, for those patients who are on both parenteral nutrition and tube feeding, those patients may not get a great service experience because they may have their enteral nutrition from one provider and their parenteral nutrition from another provider.
Correct. So a lot of parallel struggles and access issues are experienced by enteral nutrition consumers as are parenteral. Piggybacking off of Amy, we also have tremendous issue in terms of product and service availability and restrictions. So firstly, finding a DME provider, home infusion provider that's able to service your particular area that's a network and with all products available and on formulary can be a huge obstacle. And then the challenge of having to potentially use multiple suppliers if they'll allow you to split your order, like for example, maybe receiving different services if you are multi-therapy or if you require a specific modular or metabolic product that maybe one DME doesn't cover. Are you able to logistically split that in terms of allowance from the DME or home infusion provider, and the feasibility of being able to bill and get reimbursement for those services and products? The ability to obtain affordable self-pay options and rates can vary from agency and company to company, as well as potential supply substitutions that are forced upon the consumer. As Amy said too, in terms of supply options, this is further compounded in terms of all the barriers that are in existence for being able to drive innovation and allow for new product options that would potentially create cost saving or potentially help improve patient safety options and quality of life.
So this brings us to the overall impact. What really happens when we have these problems and issues of access and reimbursement is that the end result is a lack of justice for our patients, which is a key ethics cornerstone. And in these situations, high quality care becomes available only to those with significant financial means. And there's poor quality and access to care for children and to others who may have the wrong payer.
And the effect is on continuity of care, site of care, hospital length of stay, level of care, costs and burdens on the system. And ultimately, though, it will affect all stakeholders.
So for the next steps, the next steps in the committees. Out of here, what are we doing next? So how do you get involved? You get involved by raising your hand, emailing us, joining one of our two committees, either the parenteral nutrition committee or the enteral nutrition committee that we will have in the near future. But of course, skip the middle bullet. What you'll be seeing also come out in the near future is an Oley reimbursement survey that is going out hopefully to all, and hopefully will be filled out by all infusion companies that we can get, because we need this data. As Amy and Jessica was going over earlier, the data will drive what we can ask for. The data will show the increases. And so we need to take this data and demonstrate the needs for reform to our lawmakers so that we can make the reform that's needed. So please join us, get involved, and join one of our committees and help us help you. So help me as a patient, help you as the providers, so we can do this together.
All right. Thank you all so much for sticking with us here. As you could have seen on that last slide, you're more than welcome to email us at info@oley.org. We will also be sending out a follow-up email for all those who registered and attended with information regarding next steps and how to get involved. With that being said, we do have some time for questions. Feel free to use the Q&A function. It should be located up top. For me, it's to the right of my chat function. You can add them there. But in the meantime, I quickly want to turn it over to Jessica to see if, Jessica, if you have any updates or high-level comments regarding the newly released NHIA white paper, since I know you had touched on that briefly during the presentation, and of course, like the day after it got published.
Yeah, thanks, Kaylee. Yeah, so we did the recording, and I think the day of or the day after NHIA actually published the updated white paper. So figures. Initially as I mentioned at the last NHIA conference, they were projecting a 200% increase in costs, but after reviewing the data, they did determine from 2016 to 2024, the average cost of PN bags rose by 75%. So not as drastic of an increase, but still significant. And this was also at the same time that monthly payments for HPN had decreased over 5%. So costs were going up still, and reimbursement was going down. And I also just did want to echo that stat I mentioned, the 16% decrease in the number of home infusion pharmacies submitting claims for HPN. Unless something changes, this number is going to rise. And it does reaffirm our message that something has to be done to preserve patient access to home nutrition support. Like, we have to do something at this point.
Agreed. And thank you to Melissa. We have posted the link. It's open access for anybody to check out in the Q&A tab. So for those that are interested in learning a little bit more about what Jessica mentioned, you could definitely include or check that out there. While we're waiting on more questions to come in, I did want to ask the group, and Jessica, I think you touched on this a little bit, but what would you all like to communicate for those that are in attendance? What's the biggest takeaway from this presentation and next steps?
I think for me, get involved, speak out. I mean, it is hard because I'm in industry, right? So sometimes I think people may view it as, I'm working on what's in my best interest as a business, but it's not. Like, it's purely, we are all very passionate about our patients, and we want them to be able to get the care that they need. I mean, a lot of us have seen these transitions from going from one infusion company to another because, maybe they're consolidating, they're not doing acute therapies anymore. The landscape is changing, and it's heartbreaking for us to have to transfer patients and, see patients have to manage these changes. And, that's, I think, why again, as I said in the beginning, like, that's why I'm here. Like, it's time for me to also step in, speak up, and also be an advocate for patients.
Amy, do you have anything to add to that?
Sorry, I was just reviewing the Q&A that was coming in. I do actually. So one of the things I just wanted to mention is that, as a home infusion provider in a similar position to Jessica, working for a home infusion provider, it's really important for all of us who are engaged in this, even if we're clinicians and not on the business side of things, to engage with your managed care counterparts. And talk about the value that home nutrition support brings overall for quality of care for patients with any condition that requires nutrition support. So that's one thing that I would encourage everyone on this call to get involved with in some way. I know for vendors and manufacturers too, you have market access teams. Get to know those teams, and if you're a clinician or have a clinical background, share the value of nutrition support and what it means to patients.
Definitely. And right before we hear from Crystal, we received a question about how can major infusion counterparts work together to achieve patient-centered goals of care and reach insurance companies to revamp and optimize reimbursement. And that is the point of this call or this presentation, to drive those next steps and to create action items and to collaborate and work together. We will be addressing this, even though the survey is parenteral focused, we'll also be creating one that's EN focused. So we will be addressing both parts and have task force for both EN and PN, which again, we'll be sending out information regarding those in our follow-up email. With that being said, Crystal, I want to turn it over to you to hear what you have to say. And maybe if you can elaborate on a question that we got too, the best way for patients to help out get more involved when it comes to some of these concerns and issues.
So to directly answer that question, I would say one of the best ways for patients to get involved is you're the middle of the triangle, right? So the triangle is between you, the infusion company, and the prescribing physician or clinician. Physician, actually, the physician has to actually prescribe. You have a physician in there. Even though we heavily rely on, well, all three of you lovely ladies who are dietitians to do it, it's the physician that's truly signing off on it. And
for the patient to get involved, it's linking the conversation. We don't want the patient to be overly take on more because the patient has enough on their plate to already worry about. But asking the questions and linking your infusion company and your physician together, asking them if they talk regularly and how they can have a conversation, truly having the conversation between them. And then, of course, for patients, a lot of us have long conversations, too long of conversations and too much headaches with our insurance companies. So what I do is I actually have my insurance company call my infusion company directly when they are working on billing issues so that they can talk instead of me being the intermediate. And it relieves some of my energy, but they can talk the same language versus having me try to interpret it because I don't speak insurance. I speak more insurances than I wish I did, but that's one way to be able to do it. Yeah, so it's one of the things.
Definitely, and well said. Patients and consumers, they do have so much on their plates, right? And so that's why Oley is willing to lead the charge. I just want to call out Beth's comment here. So we are including the patient voice, the patient perspective, and the coalition and the community behind us. But we do heavily rely on the data, which is the point of these surveys and data collection effort that we'll be sending information out about, and the connections too. So we're running short on time, but please email us at info@oley.org with additional comments, questions, feedback. And like I've said, you will receive an email with follow-up information about how to get involved, to elect what areas of interest or expertise you have or would be willing to contribute, and then information regarding the data collection survey and next steps. Thank you all so much for your time. I'm so excited for the action and hopefully change that will come from this presentation. And like I said, please connect with us and reach out if you think of any other questions, feedback. This is just the beginning. Bye for now. Thank you, everyone.
Thank you.
Thanks, everyone.